Good morning, everyone. I have the privilege of introducing Dr. Christopher Golden, an associate professor of pediatrics at the Johns Hopkins University School of Medicine. He's clinically trained as a neonatologist, works in the neonatal intensive care units at the Johns Hopkins Hospital and the Johns Hopkins Bayview Medical Center. He also directs the Johns Hopkins Newborn Nursery and the Neonatal Nurse Practitioner Program. His clinical research interests include congenital neonatal infections, neonatal brain imaging, hyperbilirubinemia, and the care of healthy babies. He's also a pediatric medical educator, serving as the director of the Pediatrics Core Clerkship at Johns Hopkins, and he's a past member of the executive committee of the Council of Medical Student Education in Pediatrics, or COMSEP, and which is a national organization that develops the best practice strategies for pediatric undergraduate medical education. Additionally, Dr. Golden, in collaboration with 8 other national colleagues in medical education and student affairs, has developed a workshop on addressing microaggressions in medical environments that's been presented virtually and in person at medical schools and national and international medical conferences. Christopher has published medical articles on topics in neonatology and medical education in respected journals such as Pediatrics, Academic Medicine, Academic Pediatrics, the Journal of Perinatology, JAMA Pediatrics, the American Journal of Obstetrics and Gynecology, and the Journal of Pediatrics, where he serves on the editorial board. He's also the current chair of the pediatric section of the National Medical Association, which is the largest organization of African American physicians in the United States. And so with that, I give you Dr. Christopher Golden.
Baraka, thank you for that lovely introduction. I will tell you that she is the treasurer of the pediatric section of the NMA, and we spend many, many nights on Zoom together, hashing out things going on with our section, which is growing over leaps and bounds over the next few years, and we anticipate it will continue to grow even more. So I am taking off my medical education hat today, my leadership hat, and talking about my true love, which is congenital infections, by this talk that I entitled Congenital Syphilis, Yesterday and Today, from the Lenses of 3 Doctors William. These are the relationships that I will acknowledge and say that they have no influence on the content that's being presented today. And at the end of the presentation, these are the learning objectives I would like for you all to attain. This lecture will fortunately highlight on my favorite area, which is neonatology, but also obstetrics, medical history, public health, laboratory medicine, infectious diseases, and the most important characteristic, I think, perseverance. All right, so let me introduce you to my colleagues, my 3 Doctors William. Here's the youngest. I had the fortune of speaking at the American Academy of Pediatrics, NCE, back in the fall of last year. And the opening line of my comment was that syphilis has come back to the United States with a vengeance. And for those of you who've not seen the beautiful new Children's Center at Hopkins, just showing you a picture of that endowed by the Bloomberg family. Since I'm coming from Hopkins, I would be remiss if I did not include this William, who is the eldest. And again, contrary to popular belief, this doctor never said that syphilis was the great pretender. There is always this adage that this is true, but this is what he did say. He mentioned and said that he told his students that syphilis is the only disease which they are required to study thoroughly. Know syphilis and all of its manifestations and relations, and all other things clinical will be added unto you. Sir William Osler in 1897 at an address to the New York Academy of Medicine entitled Internal Medicine as a Vocation, made this comment, and again has been attributed as saying that syphilis is the great pretender, but he never actually said that. This is what his comment was. Now, I'm going to introduce you to the 3rd William. You've met me, you've met Sir William Osler, but you may not know this William. William Augustus Hinton, born in Chicago, 1883, to parents who were originally slaves from North Carolina, raised in Kansas, went to Kansas University for 2 years, then transferred to Harvard undergraduate, where he completed his undergraduate degree in 1905. In an interim 3 years, he studied bacteriology at the University of Chicago while teaching in Tennessee and Oklahoma. The college in Oklahoma is now known as Langston University. He then completed Harvard Medical School in 1912 and taught serological techniques at the Wasserman Laboratory in Boston and served as a voluntary assistant in the Department of Pathology at Massachusetts General Hospital. Unfortunately, though he was well trained and near the top of his class at Harvard Medical School, he was unable to attain a residency in medicine or surgery. So he decided to go into the laboratory and used laboratory medicine as his vehicle to understand the pathology of disease. And again, serving as a pathologist or voluntary assistant, he had the opportunity to do many autopsies on patients in the subsequent 3 years after graduation. And subsequently, but given his outstanding work, was named as chief of the Wasserman Laboratory of the Massachusetts Department of Public Health at that time. Okay, so now you've met all three Williams, and now we're going to talk about the important disease that I mentioned as well. Syphilis, a disease that has been stigmatized by country and religion. The Italian physician Frascatore named it Syphilis Morve Gallicus, the French disease. The English and Italians were noted to call it the French disease. The French, in return, called it the Neapolitan sickness. Russians referred to it as the Polish sickness. The Poles called it the German sickness. Flemish, Dutch, and Portuguese and North Africans called it the Castilian sickness or the Spanish disease. And the Japanese called it the Canton rash or the Chinese ulcer. Muslim Turks called it the Christian disease. And in northern India, the Muslims blamed the Hindi, and the Hindi blamed the Muslims for the passage of this disease. So it's been passed around and stigmatized again by country and religion. Treponema pallidum is a macroaerophilic gram-negative bacteria, sequenced in 1998, known now to contain very few integral membrane proteins, but a lot of lipids. And lipids are going to be important in just a second. Recognizing there are very few intrinsic enzymes, it relies on the host for survival. And finally, importantly, the bacteria cannot be cultured commercially on artificial medium, which is why we rely so heavily on serologic tests. Just to note, there is a physician or a PhD, Stephen Norris, who is at UT Houston, been able to actually culture it in the laboratory, but there are no commercial available tests to actually culture syphilis. Just as a reminder, syphilis congenitally can be acquired at any stage of maternal infection and at any time during pregnancy. That can occur transplacentally or with contact with maternal lesions. There have been reports of women with syphilitic breast lesions where actually the bacteria has been transmitted. By an old statement known as Kasowitz's law, for those of you who know medical history, we recognize the fact that syphilis can be transmitted in a variety of manifestations based on the level at which the mother is infected. So those with primary and secondary syphilis has a vertical transmission rate of about 60 to 100%, whereas those with syphilis only acquired as a latent infection, meaning having an infection greater than a year from the time of actual acquisition without any symptoms, have an 8% transmission rate. Important to recognize that nearly 40% of pregnant persons with early untreated syphilis will go on to have a baby with either a subsequent abortion, stillbirth, or perinatal death. And the risk of transmission increases with increasing gestational age at time of infection and with maternal co-infection with HIV. I won't bore you with the CDC's classification for what manifests as a probable or confirmed syphilis case, but I will turn to you the guidance from the Red Book. And this again is adapted from the MMWR guidelines with regards to syphilis. I always talk to my trainees in making it as 4 buckets: either proven, possible, less likely, or very unlikely. Clearly a child with an abnormal physical exam finding and laboratory testing is there. What I most commonly see in clinical practice is a neonate who has a normal physical examination, a serologic titer less than the mother's, and the mother either having not been treated with an erythromycin regimen, which is not beneficial because syphilis actually has the ability to mutate and be resistant to erythromycin, and erythromycin does not cross the placenta very well. Or the birthing parent receives the therapy less than 30 days prior to delivery. This is the bucket where I most commonly am challenged to make a decision clinically, as well as my infectious disease colleagues. But these are sort of the guidelines. So just to keep that in mind as we're going through this talk, that most commonly, again, it's that second scenario that gets us into trouble. The one that we like the most, I had a colleague in Memphis, medical school classmate of mine, called me over the weekend about a patient, and we finally were able to deduce that this mother had been treated about 3 years prior to actually becoming pregnant, and she fell in this bucket, and the child did not need to be treated. So, how many of you have seen a case of congenital syphilis? Wow, that's a lot more than I would anticipate. So for those of you who haven't, let's do a little education and talk about clinical manifestations. And what I'm also reminded of is my history professor in college, a guy named Raymond Gavins at Duke University, who always told me, Chris, if you want to get the information, go to the original sources. Don't rely on someone else's interpretation of the data. So we have a wonderful resource at Hopkins called the Welch Medical Library. And if you've ever been to Hopkins, you know there's the big four: William Halsted, William Welch, William Osler, and Howard Kelly. Those were the big four at Hopkins. What also is prominent is something called a rare book room. And I had the opportunity to go to the rare book room at Hopkins because they had 2 volumes that I was quite interested in. First was one that you probably know very well: Osler's The Principles and Practices of Medicine. The 1892 version still has residence in the rare book room. So I had the opportunity to pull some data and evidence from there. What you may not recognize is our colleague, Dr. Hinton, actually published the first book on medicine by an African-American physician called Syphilis and Its Treatment in 1936. And what I'm going to do is sample from those books and walk through the clinical manifestations of congenital syphilis. Both of them noted that the child with congenital syphilis might be otherwise healthy. And Hinton even pointed out that in 50% of all congenital syphilitics, they will show signs within the first month of life. Syphilitic coryza, which is called the snuffles, seen here in this child, appears again per Hinton as either yellow or blood tinged as a result of the inflammatory change. These snuffles, if you want to call them that, are full of treponines. Do not touch. Skin eruption. This was called by Osler pemphigus neonatorum, but this is an actual image from a patient in Italy, and it was known as pemphigus syphiliticus. That was the diagnosis. The erythematous or eczematous condition can be seen, but more often they're irregular brownish patches with well-defined edges. And this little girl from Spain has evidence of these, what we call copper penny lesions on her skin. You also notice she has a very protuberant abdomen, and it was not clear that either Osler or Hinton recognized this, but hepatitis is a clear manifestation of congenital syphilis. Walker Long and Ned Lawson at UNC in 1984 published a seminal paper on that. Finally, there are the maculopapular lesions that ultimately fissure and heal. And this little fellow, actually, who was adopted from Southeast Asia, and this was a group in Ohio, has these very fine lesions around the corners of his mouth, and these are called regades. Congenital syphilis is defined somewhat anecdotally and arbitrarily as occurring prior to 2 years of age when it's in its early manifestations. Other clinical findings include intrauterine growth restriction, bony abnormalities. This is Wimberger's sign. This is proximal tibial erosion, and pneumonia alba, which is seen here on a pathologic specimen of a patient from Spain as well. These are some other clinical manifestations of early congenital syphilis. What was not recognized, probably obviously would not have been recognized back in the day of Osler and Hinton, were in utero manifestations. This is a group from Italy which demonstrated by ultrasound of a fetus evidence of liver, kidney, and gastrointestinal involvement. And finally, you can see these autopsy specimens again from a group in Spain. Note again, the large placenta, placentamegaly is a clinical manifestation as well, and included the child here, this autopsy again, with this child with the large abdomen, again, suggestive of hepatitis. The later manifestations of congenital syphilis also were recognized by Hinton and Osler. These are Hutchinson's incisors. Jonathan Hutchinson was the British physician that first described these, but Osler, again, categorized these as these almost fang-like appearing teeth. The knees. Hinton talked about the simple effusions that are not painful, but are generally serosal inclusions, which we know as Clutton joints. The manifestations of bony abnormalities, it's interesting that Osler noted that these don't occur until about 6 years of age, and we actually recognize that sort of 2 years in the age or beyond. These are thickening of the tibia, which we know as Saber shins. And then finally, Hinton noted the evidence of interstitial keratitis. This is a child, actually a young adult from India, who has clouding of the corneas as well as keratitis, which had persisted for about 15 years, as noted in the publication that I found today. The late manifestations can include palatal perforation, what we know as mulberry molars, multiple cusps of the molars here in the back. Hutchinson's triad is noted as Hutchinson's incisors, interstitial keratitis, and hearing loss or cranial nerve 8 injury. There are other manifestations that can involve central nervous system abnormalities, including seizures. And I found this quite fascinating. There's the one image I found of Higamenakis sign, which is thickening of the sternoclavicular joint, seen here in this picture. All right, so there's our clinical review. Now let's talk about the epidemiology, and I'm going to take over as some of the things that I found. We have been tracking syphilis since 1941, and notably there was a spike around the time of the Second World War, which gradually diminished as we began to employ the use of a drug called penicillin, which I'll talk about in a bit. There was a slight uptick in the late 80s, early 90s, relative to an increase in conditions related to HIV, as well as a change in the case definition. But we had seen a steady decrease over time to the 2000s till our current day, where that increases. Now, what I'm going to show you is the rates of primary and secondary syphilis, again, the most infectious forms of syphilis in the United States from over a 10-year epoch. The darker the blue, the more significant the infection. These are cases of primary and secondary syphilis in all comers. I always like to go back and just for emphasis show that one more time. And I'll reiterate my statement. Syphilis has returned to the United States with a vengeance. What's also important to know is that the number of patients with primary and secondary syphilis based on the cases by sex and sex of sex partners has changed dramatically over a shorter window of time. This is the data in the circle, the pie graph from 2022, which reflects that there's been an increase in the number of women with primary and secondary syphilis. When I then add in the data from 2023, we note that the number of cases of primary and secondary syphilis in men who have had sex with men only has taken a dip for the first time. However, there's been a steady increase in the number of cases of women who have primary and secondary syphilis. And again, when we look at women of reproductive age, we see a similar finding. The darker the blue, the more significant the rates. This has been a common feature in the southeastern United States, and for those of you who know geography, Maryland is south of the Mason-Dixon line, so we technically here count it as the South, but that has been a problem from Maryland to Louisiana. But what has been more prominent over the past 10 years is an increase in the Southwest and in Arizona and in the southern portions of California. And as primary and secondary syphilis go, congenital syphilis goes as well. There were roughly 450 cases of congenital syphilis in 2014. In 2023, there were nearly 4,000 cases of congenital syphilis. And again, following the all stages line, you see as all cases of syphilis increased, the number of cases of congenital syphilis in the blue bars increased as well. And I don't want you to be fooled by the slight drop in the number of cases in primary and secondary syphilis, again, among women ages 15 to 44 years, because over that 10-year epoch, there's been a 488% increase in the number of cases of primary and secondary syphilis in women, overall rather, and then roughly a 580% increase in the number of primary and secondary syphilis cases among women of reproductive age. For emphasis, this is what congenital syphilis has looked like over that window. The darker the blue, the more significant the cases. And then finally, just to reemphasize what Hinton and Osler determined years ago, is that roughly 50 to 60%, it's 58.8% in 2023, of the number of cases that will have congenital syphilis that will present with no clinical symptoms whatsoever. We have to keep it on our radar. And again, I'd be remiss without focusing on the health disparities in this particular condition. Notably, in 2023, 14.1% of all infants born in the United States were identified as Black or African American. Yet, the number of congenital syphilis cases was nearly double that in the Black and African American community. And again, in the Hispanic and Latino communities, 25.6% of all births were noted to be during that time, but yet the number of congenital syphilis cases was greater than the actual number of births. Again, health disparities are clearly a problem. So where are we failing? Again, this represents 2023 data. We had roughly 4,000 cases of congenital syphilis. Nearly 40% of those cases had 49% had a timely test, but 40% of those cases had no testing done in a timely fashion. And importantly, of those who had a timely test done, nearly a fifth of them had no evidence of documented treatment during the pregnancy. This is a problem, people. And how is it exacerbated? Notably, there are no national guidelines for testing for women in pregnancy. This is data from the CDC. The top of the graph demonstrates and says 2018, but this was updated in November of 2022. It is recommended that women have a syphilis test during pregnancy. Yet we know the best practice is to have a syphilis test during registration, during the third trimester, and at or around the time of delivery. You will note that there are 8 states in the union where there is no legislation for syphilis testing during pregnancy. The caveat is that there is some legislation for those who are cared by nurse midwives, but you can look at the states of Minnesota, Mississippi, New Hampshire, and North Dakota and note that there are no laws on the books to mandate testing for syphilis for a gravid person. Maryland, in this particular slide, had testing required in the first visit, third trimester, and at delivery in high-risk areas. And there's some sketchiness about what high-risk areas meant. But only 2 states, North Carolina and Arizona, avidly tested 4 at the 3 times that I mentioned earlier. And California, since we're here, only had the recommendation to test at the first prenatal visit. What I will say in the interim is that some states, since the publication of this graph in 2023, have decided to improve their testing. The state of Georgia now tests at all 3 points. The state of Texas tests at all 3 points. The state of Nevada requires testing in high-risk pregnancies at the time of delivery. And I'm pleased to say that my home state of Maryland passed a law in October of 2024, made effective then, that requires testing at delivery for not only syphilis, but for HIV at the time of delivery. So when I trained at Hopkins, we were considered, Baltimore City was a high-risk area, and there's again some sketchiness about that. But now any woman who lives in Maryland, whether you live in Silver Spring, whether you live in Hagerstown, whether you live in Ocean City, or you live in Baltimore City, you have to be tested for syphilis and HIV by the law at the time of delivery. But this again complicates people who move from jurisdictions during pregnancy of knowing what syphilis test has been done. And then we had the issue of COVID. And one of my colleagues, who is an internal medicine resident at our community hospital, took a look at congenital syphilis cases and prenatal care during pregnancy, during the pandemic. What she noted was some of the risk factors that we always are concerned about: drug use, transactional sex, living with HIV, having a history of STIs, and identifying and noting that there were people that had either partial, limited, or no prenatal care. But when Nicole Campo Diallo, I have her picture up here, she's now an internist at BU, noted that the opportunities and barriers for actually getting appropriate care. I point out here this factor here, the fact that we were not able to have an information exchange available between hospitals. If you were in a care center that provided substance use care, your records did not automatically transfer to the primary care site or the healthcare site that you chose. And notably as well, there were opportunities for these 16 cases where women could have had encounters in the health system during pregnancy for treatment, in the emergency room, or in acute illness or substance use settings where treatment was not offered or provided. Again, there are systemic issues that are problematically affecting the way that we care for moms and care for babies. All right, diagnosis. I'm going to take the liberty of doing a little history lesson for you today. This is August von Wassermann. Does anybody recognize the name Wassermann? Wassermann is the syphilis test that we all do. So this was actually published, again, I love the Welch Medical Library. They're to find this for me. May of 1906. A serologic reaction for syphilis is the translation. I actually had the German original reprint. And one of my colleagues is from Germany in the Division of Neonatology, and she kindly translated this for me. But what Wassermann did was take apes or monkeys and inject them with either human syphilis extract or controls. This is my poor attempt at a Erlenmeyer flask or a test tube, but treated, creating an inactive serum that ultimately was mixed with guinea pig complement. As a result, that chemical was then reacted, or that mixture was reacted with some type of test material, probably some treponema material, and red blood cells, creating a slurry. The idea is that if there were no antibodies present to syphilis in the extracts that they took from the apes, the complement from the guinea pig would blind the red blood cells and create a red cell hemolysis. So you have red cells at the bottom of the tube. If, however, the sample from the ape or the monkey did have syphilis antibodies, you would have complement binding the antigen-antibody complex. This is called complement fixation for those of you who are laboratorily inclined. And this is the basis of the Wassermann test. Come back to our colleague, Dr. Hinton. He had recognized a previous study that evaluated for syphilis using a series of sodium chloride solutions. So Dr. Hinton, in his wisdom, developed a process where he inactivated the serum of patients with syphilis, created a glycerated indicator, which actually contained beef extract, sodium chloride, and glycerol, then incubated for 12 to 18 hours, and the resultant test produced something that we see here, either in the far left, a positive, in the middle, a partial positive, or the concept of one that did not react, which is the one in tan. Hinton said in his paper, a little experience with the reaction will readily indicate the characteristic difference between positive and negative reactions, provided it is borne in mind that the indication of a positive reaction is always complete clearing, as seen here on the far left, and is independent of the size of the flocculi. Flocculation. Anybody know what that relates to with syphilis? That's a physical chemistry term related to the fact that colloidal particles come out of a suspension to sediment in the form of a flock or a flake. Flocculation. This was the paper published in 1927. Can anybody recognize this journal, the Boston Medical and Surgical Journal? If you look at the font, It's very characteristic. This was the New England Journal of Medicine. And a year later, when the journal changed its title to the New England Journal of Medicine, the Hinton glycerol cholesterol precipitation test was compared and notably found to be a much more sensitive test for syphilis than the Wassermann, the Kahn, again, the sodium chloride precipitation solution that was originally described, or the slide test of Klein and Young. So Hinton made an inroad with diagnosing syphilis. And when then subsequently tested in 1934 by the US Public Health Department, it was noted that the Hinton test was as sensitive and as specific as the other test currently on the market for evaluation of syphilis. And I use this as the picture on the bottom to remind you what flocculation looks like in the current day and age. So when we do an RPR, we actually are mixing a combination of cholesterol, lecithin, and cardiolipin with charcoal. When a person's serum is then placed upon it, we get flocculation and a reaction where the charcoal particles agglutinate. So a bit of a history lesson on what testing for syphilis looked like. We are still fraught with problems with regards to syphilis testing. What we diagnose now is using something called a non-treponemal test. This is the classic RPR or the VDRL. These, again, are antibodies to lipoidal material from damaged cells and also from human cells, which makes it difficult because the positive results may occur as a result of an autoimmune disease, cancer, or HIV in a patient and giving false positives. But notably, these tests are not very good at picking up primary syphilis. Secondary syphilis, the treponemal test, are actually what we're used to, the TPPA, the FTA, the THPA. Those tests are used as confirmation of the treponemal results, and they remain positive after the initial infection. But note, again, these are not very good for primary syphilis. What happened in the 2000s was that we developed new treponemal tests that involve chemiluminescence or enzyme immunoassays that give you rapid, quick results to, again, identify patients that may have syphilis even before the RPR or the non-treponemal tests become positive. And what happened subsequently was something called reverse sequence screening, which, again, uses the treponemal specific test as the screen and the RPR as the secondary test. These are automated. They don't require a subjective eye. So my 1-to-1 could be Baraka's 1-to-2, could be Mary's 1-to-4. It takes that out of the picture. And you can process samples in very quick samples. It's basically a 96 well plate that you actually reacted in. You get either a light signal or no light signal. A beautiful paper published by Papp and colleagues out of MMWR back in the fall talked about the benefits and the drawbacks of these type of tests. It is a bit more expensive to actually do the reverse sequence algorithm, but you can batch them. The benefits of doing it the traditional way, if you have a small laboratory, you're able to do these relatively quickly, but again, there's a subjectivity that goes into place. The problem that comes in with pregnancy is that what really does a positive CIA-EIA test mean? And as in many cases, when we roll out tests for adult medicine, we don't take into consideration what's involved with women or children. And this has been an issue. So the CDC gave the following guidelines. If the treponemal test, the new wave test, was positive, you should reflex to an RPR. If the non-treponemal, the RPR, is negative, there's a discrepancy. And you should do a second test, typically the TPPA, as a way of making the difference. If the second treponemal test is positive, you can say that the woman either had syphilis, has early syphilis, or has active ongoing syphilis. And if the woman has a history of previous treatment for syphilis, there's nothing that needs to be done. The problem comes in is if the second treponemal test is negative, the CIA or EIA is then felt to be actually a test that reflects a false positive. But it has to be in the right circumstances. You have to have a low-risk population. But if we're doing the test, in many cases, we're not sure if this is a high-risk or a low-risk patient, which makes for a bit of a morass, if you will, if you ask me. So Hopkins rolled out the CIA-EIA assays in 2011. and left us as neonatologists and ID specialists and obstetricians totally confused. I had the opportunity to work with really good residents. And one of them approached me. This is Dr. May Chen. This is her faculty picture now. And May said to me, "Hey, I'm interested in doing a project." I said, "Okay, I've got this syphilis project that you might be interested in doing." She goes, "I got a friend, another one of my residents who's interested as well. This is Ibuku Nakamboyo. They started," do we have any residents in here? Okay, lesson to you. You can do research as a resident and get it published. These two women, through their residencies and their respective fellowships at Hopkins in neonatology and infectious diseases, took on the challenge of developing, along with our ID, obstetric, and laboratory medicine colleagues, an algorithm for evaluating reverse sequence testing. And in that process, we actually scooped the Red Book. We actually had the algorithm that they currently display about a year and a half before they did. So what we demonstrated in our work, that when we instituted the guideline, in the situation where a patient actually was a true positive or a false positive, the mother was, we had 65 patients in our cohort, we wound up following the algorithm to a T. When there was discordance, however, we noted that there were 8 infants in the discordant group that would not have been tested based on mom's negative RPR, but underwent an evaluation anyway. None of those infants actually was positive for syphilis. And of the 12 infants that we were able to follow through our Harriet Lane clinic, none of them ultimately developed evidence at 6 months of age of congenital syphilis. So the testing is not always the answer. You have to keep in mind there's other things that must be considered in your evaluation. Let's talk about treatment and follow-up. Notably, this is the algorithm from the Red Book. And again, it goes the 4 buckets that I mentioned: highly probable, possible, less likely, or unlikely. Again, the standby or the maintenance that we use is penicillin G. What I do want to point out, though, is there was the option for procaine penicillin or benzathine penicillin. But just as an educational point, the company that makes procaine penicillin stopped making it in June of 2022. So we no longer have procaine penicillin in our armamentarium to be able to treat patients. Furthermore, if you know, there was actually a shortage of benzathine penicillin, and we actually had to borrow from our French and Portuguese colleagues 2 formulations of benzathine penicillin G in the interim while we were short. But fortunately, there has been an uptick in the production of benzathine G to be able to treat these patients. There has been some suggestion that ceftriaxone could be used, but unfortunately, there's insufficient evidence to demonstrate the use of ceftriaxone to treat congenital syphilis. If a patient has a penicillin allergy, the patient should be desensitized. This is less common in neonates, but may be common in pregnant teenagers or women. And then finally, pregnant persons should be managed based on the stage of the infection. Notably, when you have a patient with syphilis or reactive serology at birth, or moms with reactive serology, these children should be followed through the first year of life. If they have positive non-treponemal serologies, RPRs, they should be followed until they become non-reactive. And if, unfortunately, you have a patient whose titers remain plateaued or increase, you should and have to conform to doing another test, including another painful lumbar puncture and subsequent 10 days more of penicillin. All right, so let's talk about prevention in New Horizons. Rachel Levine, in an op-ed piece in JAMA back in January, noted the national response to our syphilis epidemic and the congenital syphilis syndemic, again, the combination of syphilis and other social determinants of health, should be reaching out and advancing testing, including point of care testing, the treatment that I mentioned earlier with now the resurgence in penicillin G, and most importantly, awareness and education. This work began in a couple of states relatively early. I mentioned to you that Arizona was one of the states that was proactive and now has testing at 3 different times during pregnancy. They actually, on the right, had a control map for developing and advising patients and providers for managing syphilis. And then in the great state of Louisiana, there was an effort to identify cases in parishes in Louisiana to decrease the likelihood of infection and have providers more aware. In the state of Maryland, we hold a seminar every April during STD month, is what they call it. And we have a talk essentially focused on some STI. And in cases I've had the opportunity to work with a colleague in obstetrics, I'm going to show you later, to be able to publish and discuss and have conversations about congenital syphilis with a statewide audience. Finally, can we improve detection of perinatal syphilis? And I'm pleased to be a part of this R01 funded study called Modernizing Perinatal Syphilis Testing. We have developed or have working with colleagues across the country that have worked to use molecular testing, polymerase chain DNA, nucleic acid methods, to actually look at maternal and neonatal dyads for transmission of syphilis. And we have advanced neuropsychological testing. It's amazing that we know that syphilis has central nervous system effects, but there's been very little data done in recent years looking at CNS effects in children. The study sites are, as I said, Baltimore City, Maryland, Columbus, Ohio, Los Angeles, Houston, and San Antonio, Texas. And the ringleader of this is Irene Stafford. She's an obstetrician at UT Houston who's become a very close friend of mine. She had a beautiful paper on perinatal syphilis published in the New England Journal about a year ago. And she is the PI for this project, again, funded by NIH. We are working with partners at Baylor, USC, and UCLA. I'm, again, the site PI at Hopkins, along with my colleague Gene Sheffield, who's the head of maternal fetal medicine at Hopkins, as well as Allison Pritchard, who's a neuropsychologist over at Kennedy Krieger Institute, our children's rehabilitation hospital. The Ohio State team, those of you who know Pablo Sanchez can recognize him in the lower left corner. He is the PI at the Ohio State site. We also have colleagues from the CDC, Alan Pillay, as well as colleagues from the University of Washington who have recently joined to help us process these tests. Okay. So I'd be remiss if I didn't mention a little more about Dr. Hinton at the end. Notably, during his time after working and developing these laboratory techniques, he taught at the Harvard Medical School classes in the public health school in bacteriology and immunology. He served as a consultant to the Venereal Disease Division of the U.S. Public Health Service. He was the first African-American to attain full professor status at Harvard Medical School, becoming clinical professor of bacteriology and immunology in 1950. The Massachusetts legislature renamed the laboratory in which he worked, the Wasserman Laboratory, the William A. Hinton Laboratory, and the Massachusetts State Laboratory Institute building was renamed in his honor in 2008. Finally, this portrait actually hangs now in the Waterhouse Room, which is the administration building of the Harvard Medical School. And a little bit about this poster, just to remind you. Look in the background. You see 3 gentlemen and 1 woman. It is noted that Hinton was an advocate for women in medicine. The woman that's being portrayed there is thought to be Genevieve Stewart, who was Dr. Hinton's secretary when she first graduated from high school, and then moved on to laboratory practice and becoming a laboratory technician. Hinton taught at Simmons College in Boston. He also developed a training program for laboratory technicians that was only open to women. So you may ask, why did Hinton make these efforts? It is surmised by a writer, a biographer of him, that he was very sensitive to women because he had 2 daughters of his own, one of which you may know quite well, Jane Hinton. She developed Mueller-Hinton agar, which is the Neisseria gonorrhea and Neisseria meningococcemia medium that allows for growth of those bacteria. And of note, after all the laboratory training she did in the 40s, she went back to school and became one of the first 2 African-American women to earn a Doctor of Veterinary Medicine degree. All right, so I'm wrapping up. This quote by Hinton was very, very apropos. It's in the prologue to his book. Syphilis is needlessly common in occurrence. It's remarkably variable in its manifestations and often conspicuously cruel and deadly in its effects. For these reasons, its prevention, diagnosis, and treatment are matters which should be clearly understood by everyone engaged in medical practice. And I'll close with the following. Notably related to increases of primary and secondary syphilis in women, the rise of CS remains a health concern. We need to continue to surveil, screen, and treat, but it's problematic, as I hope I explained to you. Reverse sequence testing can have benefits, but must be couched in the understanding of the patients with whom you're working. Clinicians still need to focus on physical examination, maternal history, and risk factor determination. You can't just rely on a laboratory test. Paul Fisher in the audience knows Barton Childs, who was a faculty member at Hopkins, who used to rail at us as residents about just getting a laboratory test. And then finally, knowing the research and utilization of the diagnostics and neurodevelopmental outcomes, which you're hoping to do with our study, will help to improve the care of patients across the continuum and decrease the burden of congenital and perinatal syphilis overall. A few thank yous to some folks at Hopkins who have worked very closely with me. Barbara Dietrich is a laboratory pathologist who actually helped me. I can tell you a story about her in testing for syphilis in newborns. These are all good colleagues there, some of the trainees that are listed here as well. Dr. Julia Johnson gets a special shout out. She's my colleague who is German and was able to translate the Wassemer paper for me from German to English. And Z Hens, who works in the rare book room at the Welch Medical Library, is able to pull all of the resources that I presented here today. There are other colleagues from across the country, and as well as folks at the CDC, noted as well in the Maryland Department of Health. Whenever I've needed Maryland data, I can go to Elizabeth or Amanda and get data. And I also want to thank my wife and my son, who have been supportive of me. My son, who writes for the Washington Post, always jokes, okay, so what is it this week, Dad? Bilirubin, syphilis, or herpes? What are you talking about? So we have this running gag that goes along this week. So I told him this week it was syphilis. These are my references, and I'd be happy to take questions if you're interested.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.